Coming to the next topic of anesthesia, which is called as PAC. Come on guys, what is meant by PAC? What is meant by PAC? So PAC. So if you are relative or you might have undergone surgery, you might know what is this PAC. PAC is called as Pre-Anesthetic Checkup. PAC is called as what, guys? Pre-Anesthetic Checkup. Now guys, what is this pre-anesthetic checkup? So before taking the patient into the surgery, we take the patient, we usually send the patient, the surgeons usually send the patient to the anesthetist for a pre-anesthetic checkup. So once the patient comes for the pre-anesthetic checkup, imagine I am the anesthetist. What should I check in the patient? What should I check in the patient? What should I check, guys? I basically check for the 4 things, guys. The airway assessment, the hemoglobin. Basically, I go for many investigations, but I am emphasizing on what? Hemoglobin, the fasting status, and last is the history. These 4 things I will do in the PAC. Airway, hemoglobin, fasting, and the history of comorbidities. In these 4 things, the most important one is what? Which is the most important step in the PAC, without which your PAC is totally a waste thing? Which is the most important step, guys? Come on, think, right? If you can't think, I'll give you a case so that you can understand which is the most important thing through the case. So guys, imagine Sunday, it's basically Sunday, and I get a call from a hospital saying that there is a young lady who's posted for tonsillectomy surgery, right? And the nurse is telling me, sir, you come and do the PAC. What will I do? Imagine I am a lazy anesthetist. What am I doing? I'm neglecting that call. I'm telling the nurse that, okay, like I'll tell, okay, sister, I will try to come, but before going to the hospital, what you do is, you made your mind that you don't have to go to the hospital. You're just asking the nurse about what is the patient having any comorbidities and all. Nurse is telling she's 20 years old, sir, no comorbidities. So you have made your mind that this is a simple case, no need of PAC. You have neglected that PAC, and the next day the patient is posted for surgery. You go into the operation theatre. Now you are in the operation theatre, right? First of all, guys, for tonsillectomy, what anesthesia needs to be given for tonsillectomy surgery? Which anesthesia needs to be given? For tonsillectomy surgery, we're required to give the patient what anesthesia, guys? Come on, general anesthesia, right? So now look over here, guys. I go into the operation theatre. I am the lazy anesthetist. I go to the operation theatre on Monday. I see the patient. Patient is thin built only. I am basically assuming that she's normal. She's having everything normal. I still haven't done the PAC. Now I am directly going for general anesthesia. Guys, general anesthesia means what? General anesthesia means what? In your simple language, it is whole body anesthesia. Whole body anesthesia. In general anesthesia, there should be some aims, guys. Your aim should be, I should make the patient unconscious. I should make the muscles of the patient relax, and then I need to intubate the patient. Intubate and ventilate the patient. General anesthesia is same like committing a murder, guys. In murder and general anesthesia, the difference between murder and general anesthesia is what? In general anesthesia, you make the patient unconscious. The difference, before going to the difference, first similarity. The similarity between general anesthesia and murder is what? Whether it is general anesthesia or murder, you make the person unconscious. Second, you make the muscles relax. In murder, you just leave him to die. In general anesthesia, after making the patient unconscious and after making the muscles relax, your third aim should be what? I will secure the airway so that he breathes. It's your responsibility to make him breathe. So you will go for intubation. That's the third aim. So imagine, guys, I am into the operation theatre. I make the patient unconscious. Patient is unconscious. I make the muscles of the patient relax. Now I will go for intubation. For intubation, you require this device. You can see this device. You require this device called as what? Laryngoscope. You introduce laryngoscope into the patient's mouth. You lift the tongue. You see the vocal cords, and then you pass the tube. That is called as intubation. Now guys, look over here. The patient is posted for tonsillectomy under general anesthesia. What I'll do? I'll basically make the patient unconscious, make the muscles relax, then I'll take the laryngoscope, introduce the laryngoscope into the patient's mouth. I lift the tongue. After lifting the tongue of this patient, posted for tonsillectomy, I am not able to see the vocal cords. If I am not able to see the vocal cords, now what will happen? Now what will happen, guys? If I am not able to see the vocal cords, what will happen? If I am not able to see the vocal cords, I can't intubate the patient. If I am not able to put the tube inside the vocal cords, I am not able to see the cords, right? What will happen? The patient's oxygen saturation, which you see in the monitor, which was 100, slowly it comes to 90. From 90, slowly it comes to 80. What should you do, guys? If you were there in that scenario, what will you do? What will you do? If the patient is desaturating, you remove the laryngoscope, you go for a mask, you keep a mask, connect with the breathing circuit to a bag, that is called as bag mask ventilation. If you are not able to intubate, you go for bag mask ventilation so that the saturation comes up. Imagine your bag mask ventilation is also not adequate. Your bag mask ventilation is also not adequate. Then what will you do? You take this device called as LMA. What is this LMA? Laryngeal mask airway. You put this laryngeal mask airway into the patient's mouth and the patient will breathe, can breathe. So guys, remember, if you are not able to intubate with the help of laryngoscope, you remove the laryngoscope, you go for bag mask ventilation as the patient is desaturating. Your aim should be the patient's saturation should first come up. Okay? The next, if at all this also fails, you go for LMA. What is LMA? Laryngeal mask airway. Imagine you don't have LMA in your hospital. What will you do now? Bag mask ventilation is not adequate. Still patient is desaturating. What will you do now? Very good. Most of you will be thinking what? Sir, best is if you are not able to intubate, you cut open the trachea and put the tube from the trachea. That is called as what? Tracheostomy. That is called as what, guys? Tracheostomy. But imagine I don't know how to do tracheostomy. Now what will happen? You basically, the patient was desaturating. You go for bag mask. Bag mask is not working. You don't have LMA. You don't know how to do tracheostomy. Patient saturation becomes 0. Patient develops respiratory arrest, ultimately leading to what arrest? Ultimately leading to cardiac arrest. Ultimately leading to cardiac arrest. Now what will you do? Nothing. Young 20-year-old patient posted for tonsillectomy. Now she had died because you were not able to intubate. You will be taken to the court. In the court, the judge will ask you, why did the patient die? What will you answer to the judge? You will tell to the judge that the patient died, sir. Why? Because I was not able to intubate. The judge will tell you what? Not able to intubate a patient is never a crime. You will basically think that, okay, the judge is also in my favor, but he will ask you the next question and you will be trapped now. The next question he'll ask you is what? Did you know that your patient was having an easy airway or difficult airway before intubation? Now you will be confused. You will tell what? No sir, I did not know my patient was having easy or difficult airway. Judge will ask, did you do the PAC? PAC is what? Pre-Anesthetic Checkup. Have you done the PAC? You will answer, no sir. When you answer him no, he will book a case against you. He will ask you, why sir? Why didn't you go for a PAC? If you would have done the PAC, the outcome of this patient would be different. Yes or no? If you would have done the PAC, you would have come to know this patient is having a difficult airway. So what you will do? You will prepare yourself for the worst things. What worst things? You will tell the ENT surgeon that during intubation, if I don't intubate, you be in the theatre, you go for tracheostomy if required. If you know your patient is having a difficult airway, you will keep an LMA and other airway assisting devices. But you were not at all prepared for it. Why not at all prepared? Why? Because you were lazily enjoying your Sunday. Yes or no? Right? So guys, remember, PAC is the most important thing which is done before anesthesia. In the PAC, the most important step is what, guys? Come on. Airway assessment. Airway assessment. So 4 things are done in PAC, guys. Airway assessment, many investigations, but the most important, hemoglobin. Next, fasting status. Last is the history of comorbidities. History of comorbidities. Coming to the first step, which is called as what? Airway assessment. How will you come to know that your patient is having an easy airway or difficult airway? How will you assess the patient's airway? For airway assessment, sir, we tell the patient, we are discussing about the pre-anesthetic checkup, guys. In the pre-anesthetic checkup, what 4 things we need to do? First thing is what, guys? Airway assessment. After airway assessment, what's the next thing? Investigations. The most important one is hemoglobin. The third step in the PAC is what? After airway and investigation, the third step is what, guys? Fasting status. And the last step of the PAC is what? History. You go for the history. History means what? History of comorbidities, history of allergies, history of surgeries, but the most important step in the history is history of comorbidities. History of comorbidities. So these are the 4 things which are done in the PAC, right? In this 4, the most important one in the PAC is what? I have already told you. What is the most important one? Airway assessment. How will you assess the patient's airway? For airway assessment, I tell the patient, when a patient comes to me for a PAC and I am doing the first thing, airway assessment, I tell the patient 2 things and I assess his airway. What 2 things I need to tell the patient? I tell the patient to open his mouth. I tell the patient to open his mouth. Open mouth. And second thing, what I tell the patient to lift chin. So first is, I tell the patient to open mouth. Second is what, guys? I tell the patient to lift chin. As the patient is opening his mouth, just look over here, guys. As the patient is opening his mouth, what 2 things I need to look for? As the patient is opening mouth, I need to look for more 2 parameters. What 2 parameters? First parameter is basically, as the patient is opening mouth, you just see the structures which you can easily identify. As the patient is opening mouth, the structures that are easily visualized by you is given in a classification which is called as Mallampati classification. Which is called as what, guys? Mallampati classification. Mallampati classification, right? And second thing, as you tell the patient to open his mouth, is you look for this distance, the distance between the upper and the lower incisor, which is called as inter-incisor distance. So you tell the patient to open mouth. Second thing that you tell the patient is to lift his chin. As the patient is lifting his chin, you look for more 2 parameters. One is the parameter, just look over here, the distance between the distance between the mentum and the thyroid cartilage, which is called as Thyromental distance. And one more distance you look for is what? The distance between the mentum and the sternal notch, which is called as sternomental distance. So basically, guys, in PAC, we tell the patient 2 things and we assess 4 parameters. What 2 things we need to tell the patient? Sir, open your mouth. Second, sir, lift your chin. As the patient is opening mouth, what 2 parameters again you look for? You look for Mallampati classification in inter-incisor distance. As the patient is lifting his chin, you look for the distance between the mentum and the thyroid cartilage, which is called as thyromental distance. Other is the distance between the mentum and the sternal notch, called as sternomental distance. Sternomental distance, right? So anyways, guys, that's regarding the airway assessment. So first thing that we tell to the patient is open mouth. While he is opening mouth, you look for a classification. What is this classification called as? That classification in the airway assessment, the first classification is called as Mallampati classification. We have already discussed what is Mallampati classification. What is Mallampati classification? It is a classification based on the structures which are easily visualized to you. That is Mallampati. It is the most simple topic in anesthesia where some MCQs are being picked. Okay. Anyways, we are not talking in context of the MCQs. We are basically talking so that you get the concepts clear. What is this Mallampati? You tell the patient to open his mouth. While the patient is opening his mouth, you need to look for the structures which are easily visible to you. There are 4 Mallampati classes, guys. There are 4 Mallampati classes. The first Mallampati class is what? When do you call a patient as having Mallampati class 1? When you tell the patient to open his mouth, and while the patient is opening his mouth, if you are able to see a few structures, just look over here. If you are able, as the patient is opening mouth, if you are able to see the hard palate, soft palate, uvula with tip, hard palate, soft palate, uvula with tip, and if you are also able to see the tonsillar pillars, that patient belongs to Mallampati class 1. That patient belongs to what, guys? Mallampati class 1. Right? Second patient comes. 1 is done. When do you call Mallampati class 2? Second patient comes to your clinic. You tell him to open his mouth. While he is opening, what are you able to see? You are able to see the hard palate. You are able to see the soft palate. You are able to see the uvula, but the tip of uvula is not seen. But the tip of uvula is not seen clearly. Okay? You are able to see the tonsillar pillars. That is called as Mallampati class 2. That's called as what, guys? Mallampati class 2. Class 1 यानी के hard palate, soft palate, uvula, tip of uvula, tonsillar pillars. All the things are visible. That is class 1. Class 2 meaning what? Hard palate, soft palate, uvula, tip is not visible but tonsillar pillars are visible. That is class 2. Class 3, when do you call it as class 3? Class 3 meaning what, guys? Just look over here. Class 3 is hard palate, soft palate. Is the uvula visible? No. Is the tonsillar pillars visible? No. So that is class 3. Class 3 meaning what, guys? Only hard and soft palate visible. Class 4 meaning what? Only hard palate visible. Class 4 meaning what? Only hard palate visible. Soft palate is also not visible. Right? Only hard palate is visible. Soft palate is also not visible. That is class 4. Now you guys just look over these pictures and can you tell me which is the case of an easy airway and what are the cases of difficult airway? Look at these 4 pictures. And remember, guys, class 1 and class 2 are easy airway. Class 3 and class 4 are difficult airway. Why, sir? What's the reason behind it? In class 1 and class 2, I can see the structures clearly. That means I can put the laryngoscope easily and I can do intubation easily. Whereas in class 3 and class 4, as I am not able to see the structures clearly, doing laryngoscopy and intubation will be difficult. Right? So that's regarding what classification, guys? Mallampati classification. Once again, in the PAC, we are talking about airway assessment. You tell 2 things in the airway assessment. Open your mouth, lift your chin. As you're opening mouth, 2 parameters. In that, the first parameter is Mallampati and we are discussing about that parameter only. Mallampati classification. So in this Mallampati classification, remember, guys, there are how many classes? Class 1, 2, 3 and 4. Class 1, 2, 3 and 4. Just look over here, right there. What is class 1? Class 1 meaning hard palate, soft palate, uvula, tip of uvula, and tonsillar pillars visible. Tonsillar pillars visible. That is class 1. Whole of the Mallampati is very important, guys. Class 2 meaning what? Hard palate. Basically, in normal, you can say class 2 is all class 1 minus tip of uvula. All class 1 structures minus tip of uvula. So, hard palate, soft palate, uvula, tonsillar pillars visible. Tonsillar pillars visible. But tip is not visible. Tip is not visible. The tip of uvula is not visible. That is called as class 2. Class 3 meaning what? Only hard palate and soft palate visible. Only hard palate and soft palate visible. Class 4 meaning what, guys? What is class 4? Only hard palate visible. Only hard palate visible. These are 4 Mallampati classes. Class 1, 2, 3 and 4. Apart from these, there is one more class. Class 0. Class 0. Class 0 meaning what? Last patient comes to your clinic, you tell the patient to open his mouth. As he is opening his mouth, you are able to see the hard palate, soft palate, uvula, tip of uvula, tonsillar pillars. Basically, what is coming to your mind? Hard palate, soft palate, uvula, tip of uvula, tonsillar pillars. What comes to your mind? Class 1. But with all class 1 structures, if you are able to see the tip of epiglottis, it is class 0. Class 0 means what, guys? All class 1 structures plus tip of epiglottis visible. Tip of epiglottis visible. All class 1 structures plus tip of epiglottis visible is class 0. It is class 0. So that's regarding what, guys? That's regarding the Mallampati classification. Remember, class 0, class 1 and 2 are easy airway. Class 3 and class 4 are difficult airway. Class 0 is rarely seen, guys. Class 0 is rarely seen. Only when a patient is having a previous airway surgeries, you will see class 0. But apart from that, in some patient also you will see class 0, right? My Mallampati classification is 0. When I look into the mirror, by opening my mouth, I can see hard palate, soft palate, uvula, tip of uvula, and I am also able to see tip of epiglottis. So my Mallampati class is 0. Okay. So class 3 and class 4 are regarded as what airway, guys? Class 3 and class 4 are regarded as difficult airway. Difficult airway. Coming to the next thing. Remember, as you are telling we are discussing about airway assessment, guys. In airway assessment, you tell the patient 2 things. Open mouth and what, guys? Lift chin. As he is opening mouth, you look for Mallampati. We have done. After Mallampati, first is Mallampati. As you tell the patient is opening his mouth, you look for Mallampati. Second is inter-incisor distance. What is this inter-incisor distance? Look over here, guys. Inter-incisor distance is the distance between the upper and the lower incisor. You can look over here in this picture. The distance between, and basically as you are opening mouth, the distance between the upper and lower incisor is called as inter-incisor distance. So what is the normal inter-incisor distance in any person? The normal inter-incisor distance in any person is 4 to 5 centimeters. How many centimeters? 4 to 5 centimeters, right? But some patients will be having low inter-incisor distance. What patients will be having low inter-incisor distance? The patients who are tobacco chewers and if they develop submucous fibrosis. If they develop submucous fibrosis, they will be having low inter-incisor distance. If the patient is having fracture of mandible, they will be having low inter-incisor distance. If the patient is having fracture of TMJ, what is TMJ? Temporomandibular joint, they will be having a low inter-incisor distance. In all these cases, patients who are having low inter-incisor distance, the best way to secure the airway is by come on guys, what's the best way to secure the airway of a low inter-incisor distance patient? Is by tracheostomy. If you are not able to put the tube through the oral cavity, then directly put the tube through the trachea. That is called as what, guys? Tracheostomy. Right? So remember guys, mouth opening is done, Mallampati is done, and inter-incisor is done. Now coming to the next parameter. In airway assessment, we tell the patient mouth opening and two parameters, Mallampati and inter-incisor. Second thing that we need to tell to the patient is, sir, please lift your chin. As you tell the patient to lift your chin, two parameters you need to look for. One is the thyromental distance, other is the sternomental distance. The normal thyromental distance should be how much? 6.5 or more than 6.5 centimeters. Whereas the normal sternomental distance should be how much, guys? Sternomental distance should be how much? It is the double the thyromental distance. The normal thyromental distance was 6.5. 6.5 ka double is more than 12.5. So sternomental distance should be more than 12.5 centimeters. 12.5 centimeters. What happens, guys, if at all the patient is having, what happens, guys, if at all the patient is having a low thyromental distance or a webbed neck? Imagine a patient is coming with a webbed neck. What will happen? If a patient is having a short thyromental distance, it will be very difficult for us to intubate the patient, as he is not having any neck extension, any head extension. What will happen? It will be very difficult for us to intubate. So remember guys, the normal thyromental distance should be how much? 6.5, whereas the normal sternomental is double the thyromental, which is 12.5 centimeters, Okay, so that's regarding the thyromental and sternomental distance. So we have done the most important step in the PAC. If you guys remember, what was the first step? Airway assessment. Two things we need to look, two things we need to tell the patient, and we look for four parameters. What two things? Open your mouth, lift your chin. What four parameters we need to look for? What four parameters? While he's opening his mouth, Mallampati classification, inter-incisor distance. As he's lifting his chin, thyromental and sternomental. Airway assessment is done. Coming to the next step of the PAC, which is called as hemoglobin. The next step in the PAC is called as what, guys? Hemoglobin. How much of hemoglobin is required before any surgery? Any random guesses, guys? Any random guesses? I believe some of you are guessing hemoglobin is as 12. Some of you are guessing hemoglobin as 14. Some of you are guessing hemoglobin as 10. One is the right answer over here. 10 grams per deciliter, 14 grams per deciliter, or 12. Which is the right answer? The minimum hemoglobin required before surgery is how much? 10 grams per deciliter. Theoretically, you have to remember this. Practically, it depends on the cases, it depends on the center, it depends on many factors. Practically, we have done surgeries at a hemoglobin of 8. We have done surgeries at a hemoglobin of 7 also. But it doesn't mean that it has to be done. Theoretically, with books, we have to remember what hemoglobin is required, guys. 10. 10 is the hemoglobin required for any surgery. Right? Third is fasting status. Before performing any surgery, before posting the patient for surgery or anesthesia, we tell the patient to be in a fasting state. You tell the patient that, please bhai sahab, do not eat for some hours or few hours. Why? If I eat and go for surgery, what will happen? Will there be a problem? Yes, sir, there will be a problem. What problem, sir? What problem? There might be movement of there might be what, guys? Aspiration. Aspiration risk is there. What is aspiration? The gastric contents going into the trachea leading to a condition called as aspiration could be high if the patient is full stomach. That's why every patient who's posted for surgery, they are usually told to be in a fasting state for 6 to 8 hours. How many hours? 6 to 8 hours. So adults, they require fasting for how many hours? 6 to 8 hours. If it is an infant, how many hours of fasting is needed, guys, for infant? It depends on what the infant is on. If the infant is on formula feed, how many hours of fasting? How many hours of fasting? 6 hours. If the infant is on mother's milk, how many hours of fasting? 4 hours. If the infant is on clear fluid, how many hours of fasting? How many hours, guys? 2 hours. 2 hours. So formula feed, how many hours of fasting is needed? 6 hours. Mother's milk, 4 hours. And clear fluid, whether it is adult or infant, 2 hours is needed. Adult or infant, 2 hours is needed. My small question to you guys. Okay? A small question to you. Risk of aspiration is high in which anesthesia technique? The patient's risk of aspiration is high in which anesthesia technique? 5 techniques are there, no? Local, spinal, epidural, nerve blocks and general. The patient's risk of aspiration is high in which anesthesia technique? Obviously in a technique where you make the patient unconscious. What is that technique where you make the patient unconscious? General anesthesia. The risk of aspiration is high in general anesthesia. Will you tell the patient to be in a fasting state only in general anesthesia? The risk of aspiration is high in general only. In other techniques, there is no risk of aspiration. But still, you tell all the patients to be in a fasting state, whether he is posted for spinal, epidural or any surgery. Why? Why, guys? Why? Because you never know. Imagine a patient is there who is posted for, imagine, guys, I'll give you a case so that you can understand what I'm talking about. Imagine a patient is there who is working in a multinational company. He doesn't get that much of leaves. He was having some pain in his abdomen and he was being diagnosed with umbilical hernia. He goes toward the surgeon and he's telling that, doctor, I have been diagnosed with umbilical hernia somewhere, plus please do the surgery, right? Do the surgery today because I got a leave till tomorrow only, right? Do the surgery today as soon as possible. So you as a surgeon, you will ask, okay, when did you eat your food? When did you eat your food? The patient will be telling the doctor, 2 hours back I had a heavy meal. What will you tell the patient? Will you take the patient or will you not take the patient? Come on, guys. First of all, he's posted for umbilical hernia. Umbilical hernia or not umbilical, inguinal hernia, guys. Leave umbilical, inguinal hernia. What anesthesia will you give for inguinal hernia? Surgeon will complete the surgery in 1.5 hours. You go for spinal. You go for spinal. Now, what is the risk of aspiration in spinal? Nearly no chances of aspiration in spinal. Why, sir? Why? Because patient is unconscious. Only the lower body sensations are gone. That is spinal anesthesia. Patient is telling, I ate the food 2 hours back. Now, please take me up for surgery. Will you take him up for surgery? Yes or no? The answer is no, you won't take. The patient will be asking you, sir, you only explained me, no? There is no risk of aspiration in spinal. Then why don't you take me for surgery? Then you need to explain the patient what? During surgery, if at all any complications happen, that can happen, no? During surgery, if there is any bleeding, any hemorrhage, at that time, I should extend the time of surgery. The surgery will be extended, and at that time the spinal is given to you, no? Your surgery was done on spinal, but during surgery if any complications happen Anesthesia has to be extended. We can't extend spinal. So what we will do? We will go for general anesthesia. After giving spinal during surgery, if at all any complications happen, you switch to general anesthesia. But if you are full stomach, we can't go for it. Why? Because you might aspirate. So for any surgery, guys, any surgery done in any anesthesia technique, you go for fasting status. Fasting status is the advice. You need to tell the patient to be in a fasting state before any surgery. Okay, why? Because if any surgery complicates, general anesthesia is the option that we need to give. And for general anesthesia, the vital prerequisite patient has to be in a fasting state. Okay, so remember, guys, that is regarding what? That's regarding the fasting. But you also need to remember, even though you tell some patients to be in a fasting state, even though they might be in a fasting state, but still they are at higher risk of aspiration. There are some patients who are still at higher risk of aspiration. Who are those patients? There are some patients who you tell that 6 to 8 hours of fasting. They will be in a fasting state, but they are still at a higher risk of aspiration. Who are those patients? Patients whose intra-abdominal pressure is high, such as obese patient, pregnant lady, ascites, right? Patient having reflux problems such as GERD, hiatus hernia, or emergency. These patients are at risk of aspiration even though they are in a fasting state. So right there, guys, patients who are at risk of aspiration are just right there. Obese patient. Next, ascites. Next, pregnancy. Next, GERD. Next, hiatus hernia. These patients are at risk of aspiration. Apart from that, what, guys? Emergency surgery. All these patients are at risk of aspiration. We'll discuss later how will you intubate this patient. How will you go for general anesthesia in this patient? Okay, so these patients are at higher risk of aspiration. Now, guys, so we have done 3 things in the PAC. What 3 things we have done till now, guys? The 3 things that we have done is, we have done the airway assessment, we have done the investigation hemoglobin and fasting status. Airway assessment, I told you 2 things, mouth open and lift the chin. Okay, now airway, hemoglobin, fasting is done. Coming to the last part of the PAC. What is the last part? You look for the history of comorbidities. You look for the history of comorbidities. History of comorbidities. What are the history? History of comorbidities means what comorbidities you need to look for. You need to look for whether the patient is suffering with any disorders. What are the common comorbidities or systemic illness the patients are suffering in India? Diabetes, hypertension, coronary artery disease, right? Diabetes is there, hypertension is there, coronary artery disease is there, thyroid disorder, epilepsy is there. If a female is there, you have to take the history of OC pill. Patient is suffering with depression, you have to take the history of antidepressant drug. Okay? Smoking history, this history you have to take. Guys, why are you taking all the history? Are you worried about the diseases the patient is suffering with? Is diabetes a problem for the anesthetist? Diabetes is never a problem for me. But the drugs that the patient is taking for diabetes, that is a problem. That could be a problem. Why? Because some drugs should be safely given, some drugs should be discontinued. Some should be stopped, some should be safely given, some should be stopped. So imagine, guys, a person is suffering with diabetes, hypertension, CAD and all. What's your advice regarding it? If a person is coming to you for the PAC, you first do the airway assessment, then you go for hemoglobin, then the fasting, and last you go for history of comorbidities. You ask the patient about what? Sir, are you suffering with diabetes? The next answer would be what? Yes, doctor, I am having diabetes. Next, what you should ask to the patient? You ask the patient, sir, what medications are you taking for your diabetes? He'll tell what? Either he will be on oral hypoglycemic drug or either injectable form called as insulin. What's your advice now? If he is on oral hypoglycemic, what's your advice? If he is on oral hypoglycemic, tell the patient, sir, don't take the dose of oral hypoglycemic drug on the day of surgery. Skip the morning dose of oral hypoglycemic drug on the morning of surgery. But this patient is a bit genius. Genius means not genius, Google genius. Nowadays we are having Google patient, yes or no? When you advise this, he will search on Google, what is the doctor talking about and all. He'll ask you immediately, sir, why should I stop oral hypoglycemic drug? You tell him that you're stopping the oral hypoglycemic. He'll basically ask you, sir, why should I stop oral hypoglycemic drug? The surgeon told me that if I don't control my blood sugar level, after surgery my wound won't heal properly. So what will you advise him? What will you tell him? Tell him that oral hypoglycemic drugs are stopped on the day of surgery due to some reason. That reason is you are in a fasting state. If you take oral hypoglycemic drug, your blood sugar levels will come down drastically. You will develop severe hypoglycemia. This genius is now telling you, sir, normally every day I take this oral hypoglycemic drug in a fasting state, but never I develop hypoglycemia. Then please explain to this patient about what? Sir, every day you take this oral hypoglycemic drug and after that you will be eating your breakfast, idli, puri, samosa, biryani or something. Yes or no? You will be eating something. But here you are posted for surgery, not for eating biryani or samosa or idli and all. Yes or no? So you tell the patient to be in a fasting state. You tell the patient not to take oral hypoglycemic drug on the day of surgery. Why? Because if he takes, the patient will develop severe hypoglycemia. You explain him that if he takes, he is not being offered any food. He will be going for a surgery. During surgery, he will be not given any food. After surgery also, you won't give him any food. So if he takes the oral hypoglycemic drug on the day of surgery, there will be severe hypoglycemia. Oral hypoglycemic drugs are stopped. But what is your advice regarding insulin? Regarding insulin, the advice is what, guys? Regarding insulin, what you advise? You tell the patient, continue insulin without any problem. Why, guys? Why do you need to tell the patient to continue insulin? Why? Why? Because remember, insulin dose can be titrated according to the blood sugar level. Oral hypoglycemic drugs come in a fixed formulation. The dose can't be titrated. So what's your advice regarding oral hypoglycemic? Stop it on the day of surgery. Insulin, continue it, but titrate it according to the blood sugar level. Titre yani ke kya? You tell the patient, check your blood sugar level, and if your blood sugar level on the morning of surgery, if your blood sugar level is very high, then you take this dose of insulin. But if your blood sugar level is low, you can skip the dose also. So that's regarding what, guys? That's regarding diabetes. If a person is posted for a major surgery and he is diabetic, he's taking oral hypoglycemic drug, what you need to do? Stop the oral hypoglycemic drug at least 48 hours before surgery and switch to insulin. Insulin can be safely given, but titrated according to the blood sugar level. That's the advice regarding diabetes. Second disease the patient is suffering with is what, guys? Hypertension. If the patient suffers from hypertension, what is your advice? What's your advice, guys? First ask him, what medications are you taking for hypertension? What he will tell? Sir, I am taking ABCD. Any one of the ABCD. You know what is ABCD? A stands for ACE inhibitors and ARBs. B stands for beta blockers. C stands for calcium channel blockers. D stands for diuretics. ABCD. A stands for what, guys? ACE inhibitors and ARBs. B stands for beta blockers. C say calcium channel and D say diuretics. Any one of the four you can take. ABCD, any one of the four. ACE inhibitors or ARBs, beta blockers, calcium or diuretics. But what's your advice? You tell the patient to stop BCD. Sorry, you tell the patient that I am not having any problem with the BCD. I am having the problem with A drug. What is the A? ACE inhibitors and ARBs. You tell the patient that stop ACE inhibitors and ARBs on the day of surgery. Why? Because they are usually long acting and they will cause severe hypotension during surgery. Severe hypotension during surgery. So remember guys, antihypertensives should be continued in a same dose except ACE inhibitors and ARBs. Whereas oral hypoglycemic, I told you what, they should be stopped before surgery, right? And if it is major surgery, you require to shift to insulin at least how many hours? 48 hours before surgery. Next is, if the patient is suffering with coronary artery disease, what's your advice? Come on guys. CAD patient, what's your advice? For CAD patient, your advice totally depends on what drugs the patient is on. Any CAD patient will be on what basic line of drugs, guys? Aspirin, clopidogrel, right? Statins, anti-anginal drugs such as nitroglycerin, anticoagulants such as heparin, warfarin, low molecular weight heparin. These are the drugs. Some of the drugs regarding the heart disease, some of the drugs can be continued and some should be stopped. The drugs that could be continued, sorry guys, the drugs that can be continued in heart disease. The drugs that can be continued in heart disease are what? First, we need to know what the drugs which are continued in heart disease. The drugs which can be safely given in heart disease is aspirin. It can be safely given. Aspirin, 75 milligrams is nothing, guys. It's a baby aspirin dose, safely given. Next, apart from aspirin, what can be safely given? Statin can be safely given without any problem. NTG, nitroglycerin, can be safely given. The drugs that needs to be stopped are the drugs that needs to be stopped in context of heart disease. I am talking about. Okay, in context of heart disease that needs to be stopped are very important. Clopidogrel. Clopidogrel, it should be stopped at least 8 days before surgery. It should be stopped at least 8 days before surgery. Next, heparin. It should be stopped at least 6 hours before surgery. Then there is low molecular weight heparin. It should be stopped 12 hours before surgery. Then there is warfarin. Warfarin. It should be stopped 3 to 5 days before surgery. 3 to 5 days before surgery. Right? We were talking about the history of comorbidities. Under that, we were talking about the heart disease. After the heart disease, we need to cover some more disorders. If the female patient is there, you need to take the history of thyroid disorder, epilepsy disorder, and occipitals. Okay? So remember guys, if the patient is suffering with thyroid disorder, whether it could be any thyroid disorder, right? What's your advice? Tell her to continue the medications. If the patient is suffering with epilepsy, tell her to continue the anti-epileptics. Tell her to continue the anti-epileptics. It won't be a problem. If the female is taking occipit, what is your advice? Normally only leave the surgery. Normally any person who takes occipit, if she comes to your clinic and she tells you, doctor, I'm having this habit of taking the occipit. Is it a good or a bad thing for my health? Please advise me something. If the patient is telling you this, what will be your advice? You advise the patient that occipit is always bad for your health. Why it is bad for your health? Why? Because in the occipit, the estrogen component is usually bad for the health. Why? Because if the person is taking estrogen for a longer period of time, it makes the blood more thick, and that blood, the thick blood, will form clots. If the clot is being formed in the leg, the patient develops deep venous thrombosis. If that clot forms in the brain, patient develops stroke. and the patient, if that clot forms in the heart, the patient develops MI. So remember, normally occipital chronic use can cause thrombus development, clot development and all. So before surgery, what's your advice? Is it advisable to take or stop? Remember guys, as surgery itself, after surgery, will you make the patient immediately walk? No. You won't make the patient immediately walk. Why won't you make the patient immediately walk? Why? Because basically the patient might be having some problems. You tell the patient to be in a lying down posture. As the patient is lying down for a longer period of time after surgery, patient is at higher risk of developing thrombosis. If the patient takes occipitals and goes for surgery, the risk of thrombosis will be double. So what we need to tell the patient, please stop occipital at least 4 weeks before surgery. At least how many weeks, guys? 4 weeks before surgery, especially the estrogen containing. Progesterone containing can be safely given, but estrogen containing drugs needs to be stopped at least 4 weeks before surgery. If the patient is on lithium, you know what is lithium? Lithium is a mood stabilizing drug. Take a maniac disorder patient is on lithium. If the patient is taking lithium, what is your advice? The advice regarding lithium is what? You tell the patient to stop using lithium at least 24 hours before surgery. 24 hours before surgery. Why guys? If the patient is taking lithium and the patient is posted for surgery, what would happen? The lithium will be circulating in the patient's blood. That lithium does friendship with the muscle relaxants. Usually lithium causes problem in the GA cases, general anesthesia cases. That lithium does friendship with the muscle relaxant. It prolongs the effect of muscle relaxant for a longer period of time, which can be a problem to the patient. Yani ki patient won't recover easily, right? So lithium, what's your advice guys for lithium? Stop it at least 24 hours before surgery. If the patient is on MAO inhibitors, you know what is MAO inhibitors? Monoamine oxidase inhibitors. What's your advice? If the patient is on monoamine oxidase inhibitors, it should be stopped 3 weeks before surgery. Nowadays, we are having a new generation monoamine oxidase inhibitor, which is called as salicylic, which can be safely continued. Salicylic can be safely continued on the day of surgery, right? So we have discussed almost all of the drugs. Now, if the patient is telling, doctor, I am a smoker, should I continue smoking before surgery or should I stop smoking before surgery? Ideally, your answer is what, guys? Stop it only. Smoking is not good. Smoking is injurious to health. But in context of surgery, how it is injurious to health? If a person is a smoker, due to his smoke contains nicotine. Due to the nicotine content in the smoke, he will be at risk of developing bronchospasm. Hence, we tell the patient to stop smoking at least for how many weeks? 6 to 8 weeks before surgery. Smoking needs to be stopped at least how many weeks? 6 to 8 weeks or 1.5 to 2 months before surgery. Remember guys, these all advices that you are giving the patient to stop this drug, stop smoking and all, it works in elective surgery. All these advices work in what surgery? Elective. You know what is elective surgery? A planned surgery. It never works in emergency. Emergency, there is no role of this. In emergency, you have to take the patient. You can't tell the surgeon that the patient is on clopidogrel, sir. Patient is just smoked in the morning. I can't take. In emergency, your advice doesn't play an important role. In elective surgery, it plays an important role. In elective surgery, remember guys, what will you advise for diabetes? Stop oral hypoglycemic, continue insulin. For hypertension, stop ACE inhibitors, ARBs, continue BCD if the patient is on. If the person is suffering with heart disease, continue 3 medications: aspirin, nitroglycerin, statin. Stop what medications? Clopidogrel needs to be stopped. That, remember guys, in the heart disease, 3 medications you have to remember. Aspirin needs to be continued. Clopidogrel needs to be stopped. How many days? That was an MCQ. 8 days or 1 week before surgery, you have to stop clopidogrel. Heparin needs to be stopped 6 hours before surgery. Warfarin 3 to 5 days. Okay. Next, So all these advices plays an important role for elective surgery. Now guys, I'll give you a case. A patient is there who meet with a road traffic accident, who develops a head injury, who's being diagnosed with intracranial bleed. Intracranial IC bleed is being diagnosed with, right? So now he is brought to the hospital. The surgeon is saying that I will do a craniotomy. I will remove this blood from the patient's skull and all. The best anesthesia that you need to give to this patient. Remember guys, the best anesthesia that you need to give to this patient is what? General anesthesia. In some of the patient, local can be given if the patient is very much drowsy. In some of the patient, conscious sedation can be given. That is different. But normally, what we go? General anesthesia. We go for general anesthesia, right? Now, the patient is posted for an emergency surgery. Imagine he is a smoker and he is taking clopidogrel. Will you tell the surgeon, we'll wait for 8 days, sir, he is on clopidogrel? Or will you tell the surgeon, he's a smoker, sir, he will develop bronchospasm, we will wait for 2 months for the surgery? Surgeon will not listen. Why? Because ethically it's not at all good. Ethically kya bhai? The patient will die. If you wait, if you keep on prolonging, the patient will die. Leave the ethics, patient will die. So what is required over here? Emergency surgery. Now the patient is a smoker and he is on clopidogrel. In this emergency scenario, what will you do? Ideally, smoking should be stopped 6 to 8 weeks before surgery. Ideally, clopidogrel needs to be stopped 8 days before surgery. But you don't have the time to stop. What will you do now? Remember guys, there is a difference between a good doctor and just doctor. Always strive to become a good doctor, not a just doctor. What is the difference between a good and a just doctor, guys? Right? A just doctor means what? Just you got a doctor title. A just doctor person means what? He will basically wait for the complications. He will wait for the complications and then he will manage it. A good doctor, when a person comes with a disease, he will anticipate the complication. Okay, this complication might happen to this person. This complication might happen to this patient. He will anticipate and he will plan accordingly. So always try to be a good doctor. Always anticipate. Learn this habit of anticipation. Even though you might not take anesthesia as your residency, or some of you might take, but learn this habit of what? Anticipation. Anticipate all the complications beforehand, right? Remember guys, it's basically, imagine there is raining, okay? And you have been alerted by the government that there will be rain. There will be rain. Imagine you are living in a place where it doesn't have any shed. You have been alerted by the government that in 2 days there will be much rain. So if you are an intelligent person, what will you do? When you have been alerted, you will basically make a shed so that the things which are present in your small room, they won't get destroyed. That will be that an intelligent person does. But a normal person without intelligence, what will he do? He'll take the things lightly. We will see. When the rain comes, then I'll prepare. What will happen if the rain comes? What will happen? Now you will be having time? No, you won't be having time. Now the things get destroyed and all. So remember guys, always before complications occur, you have to anticipate. Not only in anesthesia, in every field of doctor, you have to, in any of the residency programs, whether it is surgery or anything, you have to learn this habit of anticipation. What bad can happen, prepare yourself for it, and then go for it. Okay, so that's basically so again, coming back to a case, a patient was posted for craniotomy. He was having an intracranial bleed. He was taking clopidogrel and he was a smoker. What will you do in this time? What will you do, guys? If I was there, what will I do? I am basically anticipating the complications of clopidogrel. If the patient is on clopidogrel, it is an antiplatelet drug which will cause much bleeding. So what will I do? I'll take my phone and I'll call the blood bank and tell what? Sir, I am anticipating some blood loss. Please arrange some blood for the patient, some platelet for the patient. So during surgery, if at all he has blood loss, at that time I don't have to rush. So basically I have prepared for it. Second, he was having what? Smoke. He was a smoker. Ideally, it should be stopped 6 to 8 weeks before surgery for or elective. But in emergency, what we do, guys? In emergency, we are anticipating, okay, he is a smoker, means he will develop bronchospasm. Before surgery, I'll prepare myself with what? In the hospital, in the operation theater, I'll keep a bronchodilator. So that during surgery, if he develops bronchospasm, I'll give what, guys? Bronchodilators. So learn to anticipate, guys. Learn to anticipate, okay? So in the PAC, remember, whole of the PAC that we have discussed, it plays an important role for elective surgeries, not emergency. In emergency, you have to act accordingly. You have to anticipate the things and then you have to manage those things, okay? So anyways, guys, smoking should ideally stop how many weeks before surgery? Smoking should ideally stop 6 to 8 weeks before surgery. 6 to 8 weeks before any elective surgery. Now, guys, we are done with the PAC. In the PAC, as I have already told you, the most important step in the PAC is what? Airway assessment. After airway assessment, what is the next important thing in the PAC? It is the hemoglobin. After hemoglobin, fasting status. And after fasting status is what, guys? After fasting status, what we need to know? We have done the airway, we have looked for the hemoglobin, the fasting, and last is what? History of comorbidities. History of comorbidities. These are the 4 things that we do in the PAC. These are the 4 things that we do in the pre-anesthetic checkup, right? So now after completing your PAC, you give a certificate to a patient. You give a certificate to a patient. What is that certification called as? That certification is called as ASA certification or ASA classification. That certification is called as ASA certification or ASA classification. What is ASA? American Society of Anesthesiologists. American Society of Anesthesiologists. Basically, that is after doing the PAC, you give a certificate or you give a fitness to the patient that you are fit to undergo what? It's not surgery which is coming to your mind. You are fit to undergo anesthesia. Fit to undergo anesthesia, right? Now, after completing the whole PAC, you give the certificate. This ASA classification depends on the systemic illness the patient is suffering with. Depends on systemic illness the patient is suffering with. Systemic illness. Diabetes is a systemic illness. Hypertension is a systemic illness. Heart disease is a systemic illness. CKD is a systemic illness. CAD is a systemic illness. Is pregnancy systemic illness? No. Ectopic pregnancy? No. Appendicitis? No. Okay? So ASA depends on the systemic illness the patient is suffering with. There will be 6 patients, guys. In ASA, there will be 6 patients. I'll give you with the examples. There are 6 ASA classes, guys. ASA 1, 2, 3, 4, 5, 6. Okay? 6 ASA classes or 6 ASA patients. The first 4 ASA classes, this patient will come to your clinic for PAC. The last 2 patients, class 5 and class 6, these are usually the sick patient in the ICU. You have to go towards the patient and then you have to do the PAC. Okay? So anyways, let's look over here. The first 4 classes. Basically, I told you ASA depends on what? Systemic illness the patient is suffering with. So imagine there is a 20-year-old female who comes to your clinic who's posted for some surgery. You ask the patient, are you suffering with diabetes? Are you suffering with hypertension? Patient is telling, no sir, I am not having any underlying disease. I am just having some hernia problem. I am not having any systemic illness. So any patient who is free from systemic illness, patient free from systemic illness comes under what category, guys? Comes under ASA 1. Patient free from systemic illness comes under ASA 1. ASA 2. When do you call it as ASA class 2? Second patient comes to your clinic and tell the doctor, I have been diagnosed with hernia. We'll take hernia as an example, okay, for all the patients. I have been diagnosed with hernia, but I am suffering with diabetes. I am suffering with diabetes. You take her fasting blood sugar level. Her fasting blood sugar level comes as 90. You take her post-lunch blood sugar level. Her post-lunch blood sugar level comes as 110. Is it in the normal or the abnormal range, guys? Very much normal. We are not diabetic. If we go for a blood test, if we go for a blood sugar test, in the fasting state, my blood sugar level will be 80 or 90. Her is also 90. And even though she is diabetic, she is having very good control of blood sugar level. So any patient who is having systemic illness which is well under control comes under ASA 2. Patient having systemic illness which is well under control, which is well under control. That is ASA 2. Then there is ASA 3. ASA 3 means what? Third patient comes to my clinic for PAC. The patient is telling that, doctor, I am having diabetes. Okay? Basically, patient is telling, doctor, I have been diagnosed with hernia. I have been posted for hernia surgery. I am having diabetes. You check a fasting blood sugar level. The fasting blood sugar level is 200. You check a post-lunch blood sugar level, it will be 400. Any person who is having systemic illness, is it controlled or uncontrolled, guys? Uncontrolled. Any person having systemic illness which is not under control comes under ASA 3. Whole ASA classification is important, guys. Patient having systemic illness which is not under control. Which is not under control. It is ASA 3. ASA 3. Okay, class 1 is done, 2 is done, 3 is done. 1 is free from systemic illness, 2 is having systemic illness well under control, 3 is having systemic illness not under control. ASA 4, this patient comes to your clinic. There is a 40-year-old guy who is coming to your clinic. He is telling you, doctor, I have been diagnosed with hernia. We'll take example, same hernia. You will ask the patient, are you suffering with diabetes and hypertension? He is telling, no sir, I don't suffer from diabetes and hypertension. Now you are happy to write that this patient is free from systemic illness and again he belongs to class 1. But slowly this patient will tell you what? Doctor, there is one thing that I forgot to tell you. 1 month back, recently 1 month back, I had an MI. MI is myocardial infarction. So any patient who is having a systemic illness which is life-threatening, which can cause a threat to his life during surgery, that patient comes under ASA 4. ASA 4 means what? Patient having life-threatening systemic illness. Patient having life-threatening systemic illness. Patient having what, guys? Life-threatening systemic illness. That is ASA 4. ASA 4. Next is ASA 5, guys. When do you call it as ASA class 5? ASA 5. When the patient comes to you, patient is not coming to you. You have to go towards the patient and then you have to check, right? So basically you will be getting a call from the hospital. In the ICU, there is a patient who is posted for surgery. Sir, please come in the ICU and manage the patient. You go in the ICU, you will see what? Patient is lying down in the ICU bed. He is posted for some surgery. You check the case sheet, you will see what? He is having diabetes uncontrolled, hypertension uncontrolled, CAD, CKD, CVA, on dialysis. Yani कि patient is having multiple comorbidities. Without surgery, the chances of survival is very less. That patient comes under ASA 5. That patient is also called as a moribund patient. So what is ASA 5, guys? ASA 5 means patient having multiple comorbidities. Patient having multiple comorbidities. Multiple comorbidities, right? And without surgery, the survival chances are less. The survival chances are less. That is called as ASA class 5. This patient is also called as what patient? Moribund patient. Moribund patient. ASA 6 means what? Brain dead patient. ASA 6 means brain dead patient. Right? These two patients, will they come to you? Brain dead patient cannot move from the ICU. This moribund patient is also not moving in the ICU. You have to go towards the patient and you have to give the classification. So remember guys, ASA is American Society of Anesthesiologists. It is a certificate that is used or that is given to certify the patient whether he is fit to undergo anesthesia or not. Right? That is ASA certification. To all these ASA certificates, you can add an alphabet E. Depending, not every case. Why do you add the suffix E? If the surgery is an emergency, then you add E. If the surgery is not a non-emergency, don't add E. So guys, imagine a 20-year-old female who's been diagnosed with hernia and she is not having any systemic illness. She comes under which ASA class? ASA I. ASA I. A 20-year-old female diagnosed with ruptured ectopic pregnancy, suffering with diabetes, with a fasting blood sugar level of 200, post-lunch blood sugar level of 280. She belongs to which ASA class? Patient is being diagnosed with ruptured ectopic pregnancy, having diabetes, which is controlled or uncontrolled. Uncontrolled systemic illness, she is class 3. But she is being posted for what surgery? Ruptured ectopic pregnancy is an emergency. So she belongs to what guys? ASA 3E. So E would be added when the surgery is an emergency. If there is no emergency, non-emergent surgery, don't add E. Right? E is added if it is also surgery is an emergency. Right? So this was regarding what? This was regarding the ASA classification. ASA classification. Okay.